Hello everyone, welcome to Easy Medicine. Today we have this 60-year-old male who presents with 1 month history of shortness of breath and wheezing. He had similar episodes in the last winter. He's a chronic smoker and alcoholic. What is the diagnosis and how would you like to treat this patient? So with the background of smoking and the presentation with shortness of breath and wheezing, this points us towards the diagnosis of chronic obstructive pulmonary disease. How would you like to treat this patient? Before we delve into the treatment, let's understand all the components of COPD, that is etiology, clinical features, and management. So we are going to discuss this topic in this brief outline with definition, risk factors, different types of emphysema, pathogenesis, clinical features, evaluation, and management. The COPD has three main components: a disease of alveoli, which is emphysema, a disease of large airways, which is chronic bronchitis, and a disease of small airways, obstructive bronchiolitis. Emphysema is nothing but an irreversible dilatation of respiratory bronchioles and alveoli. The chronic bronchitis is chronic inflammation of bronchi and large airways. Obstructive bronchiolitis is chronic inflammation of bronchiole or small airway. In a patient of COPD, chronic bronchitis and emphysema are present in different proportions. What you need to remember is that we cannot find the cases of chronic bronchitis alone or emphysema alone. What I want to emphasize here is that both of them may be present in the same patient but at different proportions. So some of them may be having emphysema predominant COPD and some of them may be having chronic bronchitis predominant COPD. COPD is the third leading cause of death worldwide, and the chronic bronchitis has been given a clinical definition, that is, a productive cough for a duration of 3 months per year for 2 consecutive years with no other explainable cause. That defines chronic bronchitis. Now let's look at the risk factors for COPD. We have environmental risk factors, and the smoking is the commonest one. The smoking exposure is measured in the number of pack years that determines the duration of smoke. The pack years is calculated by using the formula number of packs of cigarettes that the patient consumes per day times the number of years that the patient has consumed cigarettes. We have indoor and outdoor air pollution as well as an independent risk factor. Then we have low socioeconomic status, infections like tuberculosis and HIV. We have host based factors. The most important one is alpha 1 antitrypsin deficiency, which is an antiprotease. When the antiprotease levels are decreased, there is imbalance between the proteases and antiproteases, and increased protease activity will result in destruction of the lung. And finally, airway hyperreactivity. All these factors may result or predispose the patient to develop COPD. Now let's understand the anatomy of the secondary pulmonary lobule. Here is the visceral pleura, and here is the interlobular septum, and along the interlobular septum are aligned lymphatics, and here is the pulmonary vein, and in the center of the pulmonary lobule there is pulmonary artery. Accompanying the pulmonary artery we have the respiratory bronchiole, and a bunch of grape like structures aligned around the respiratory bronchioles are nothing but these alveoli. Having understood this anatomy of the secondary pulmonary lobule, let's try to classify emphysema based on it. So we have three different types, starting with the centriacinar or centrilobular emphysema. The word itself is telling you the central part of the lobule is involved. That is, respiratory bronchioles are the ones that get involved here. And this disease is usually upper lobe predominant and commonly associated with smoking. The second, we have pan-acinar emphysema, where the entire lobule is involved, that is, respiratory bronchioles and the alveoli are involved. This disease is lower lobe predominant and seen with alpha 1 antitrypsin deficiency. Last one, we have the paraseptal emphysema. The word again is emphasizing that the alveoli, which are present just beneath the septa or the pleura, are getting involved. So what you can call the subpleural alveoli are the ones that gets involved here commonly. And this disease is also upper lobe predominant and again associated with smoking. Now let's see the pathogenesis. Because of smoking or some kind of genetic predisposition, oxidative stress inside the lung, there is chronic inflammation, and there is protease antiprotease imbalance, that is increased level of proteases and decreased level of antiproteases. One such genetic cause is alpha 1 antitrypsin deficiency. So all these three will result in extracellular matrix destruction, that is digestion of collagen, digestion of elastin because of collagenases and elastases. These are nothing but the proteases, right? So because of this destruction of the extracellular matrix in the lung, that is supportive tissue of the lung, and its eventual replacement in fibrosis is the basic reason behind all the clinical manifestations of COPD. So how does it affect the alveoli? How does it affect the airways? Let's see. So when there is involvement of alveoli, the alveolar wall damage happens and it is eventually replaced with fibrosis. Since the elastin content in the alveolar wall is reduced, the alveoli are hyperinflated. And because of hyperinflation, what happens? There is significant increase in dead space ventilation. The alveoli, which are actually of this size, are increased now, and the air is not useful for air exchange. Why? Because there is damage to the alveolar wall as well, and the perfusion of gases or gaseous exchange across this barrier is also reduced. So there is increased ventilation and reduced perfusion that will result in VQ mismatch that further results in decreased PaO2, hypoxemia. Because of hypoxemia, there is triggering of respiratory centers in the brainstem and there is increased respiratory effort. Increased respiratory effort washes out the carbon dioxide and the patient will have PaCO2 reduced, right? So this is type 1 respiratory failure where PaO2 is reduced and PaCO2 is reduced. Now, when this COPD or this emphysema advances to a later stage where the patient will not be able to take in sufficient breaths, this washout of CO2 is happening only because of hyperventilation. When the patient no longer can hyperventilate and the alveolar wall is significantly damaged, there is reduced PaO2, and because of reduced respiratory rate, there is retention of CO2. This is called as type 2 respiratory failure. Okay, so in an early emphysema, there is type 1 respiratory failure, and in late phase of emphysema or advanced emphysema, there is type 2 respiratory failure. Now, because of this hyperinflation, because of this alveolar wall damage and fibrosis, the exchange of gases is reduced, but that is visible in the form of an investigation called as diffusion lung capacity for carbon monoxide. That is reduced. And because of hyperventilation, what do you think will happen to the lung volumes? The lung volumes, like residual volume, is increased. The dead space is increased, which is visible in the form of increased residual volume. The capacities which incorporate residual volume are also increased. So the functional residual capacity, total lung capacity are increased and the vital capacity is reduced. Now let's see the effect on the airways. When you look at the effect on the airways, there is mucus gland and goblet cell hyperplasia, and there is also significant fibrosis in the airways as well. When this pathology affects the larger airways, the patient will have productive cough. When this affects the larger airways, the patient will have productive cough. But when this affects the smaller airways, there is obstruction of the smaller airways, and the ventilation for those alveoli which are supplied by these smaller airways is reduced. So the ventilation is reduced, but the perfusion is maintained. Remember, in when we are talking about airways, the alveoli are supposed to be normal and the perfusion is supposed to be normal. Okay, so there is reduced ventilation and perfusion is normal. What do you think will happen to the VQ ratio? It is also reduced, and hence the PaO2 is reduced, PaCO2 is increased because the carbon dioxide inside the alveoli is not going out and oxygen in the environment is not going to enter into the blood. So there is reduced PaO2 and increased PaCO2. This is again type 2 respiratory failure. Let's see the effect of hypoxemia on the lung. So when the patient has hypoxemia, there is reflex pulmonary vasoconstriction. What do you think is this? This is actually supposed to be a compensatory or a protective mechanism. Let's suppose there are two alveoli. One of them is damaged now, and the pulmonary vasculature supplying this alveoli gets vasoconstriction. Why is it? Because the vasoconstriction here will shunt the blood towards a normal alveolus that facilitates proper oxygen exchange or proper gaseous exchange. But what is happening here in COPD? There is diffuse damage to the alveoli. This is not a localized damage. This is bilateral and a diffuse damage to both the lungs. So all the alveoli are uniformly damaged and there is pulmonary vasoconstriction all throughout the lungs. That will result in pulmonary hypertension, and because of long-standing pulmonary hypertension, the patient will eventually land up in right heart failure, or it is called as cor pulmonale now because this right heart failure is because of the lung damage, and the patient will have edema. This hypoxemia, prolonged hypoxemia, can also increase the production of red blood cells in the body, and the patient will have polycythemia. These patients with reduced PaO2, prolonged hypoxemia, the patient will develop cyanosis. And since these patients are also having edema, these are called as the blue bloaters. Blue bloaters. So this is an image demonstrating the effects of COPD. As you can appreciate in the right lower image, the airway lumen is significantly reduced. There is mucus hypersecretion and exudate in chronic bronchitis, and you can also appreciate in the wall there is mucosal inflammation and fibrosis. Try to differentiate emphysema and chronic bronchitis. The emphysema patient is characteristically called as pink puffer, but this term is outdated now. Dyspnea is very severe, and the respiratory effort is increased that will eventually result in increased carbon dioxide washout and cachexia. The hypoxia is late, and the patient will have hypocapnia. Type 1 respiratory failure is predominant here. DLCO is reduced, the vital capacity is reduced, and the residual volume, functional residual capacity, total lung capacity are increased because these capacities also incorporate residual volume into them. Chronic bronchitis are called as the blue bloaters. Dyspnea is mild and there is reduced respiratory effort and the patients are usually obese. Hypoxia is early and hypercapnia is dominant here. Because of hypoxia and hypercapnia, you call it as type 2 respiratory failure. And DLCO is normal, vital capacity is normal, residual volume, FRC and TLC, all of them are normal because we are not dealing with the alveoli here. It is only a disease of airways. So when we are talking about emphysema, we are talking about emphysema predominant COPD. When we are talking about chronic bronchitis, we are talking about chronic bronchitis predominant COPD. We are not talking about emphysema or chronic bronchitis alone in a real case. Let's see the clinical features. The cardinal symptoms are exertional dyspnea, chronic cough, and sputum production. The patient will also experience wheezing and chest tightness. In the late stage, the patient will have some characteristic features. One such one is pursed lip breathing. The patient usually sits in a tripod position. The patient will also show a Hoover sign. The patient will have rapid shallow breathing, and because of increased respiratory effort for a prolonged period of time, the patient will have fatigue and cachexia. And of course, chronic COPD will result in right heart failure, and that is called as cor pulmonale. The features of cor pulmonale like bilateral pedal edema, congestive hepatomegaly, ascites may be the eventual result. We are discussing about the Hoover sign. So this is a normal diaphragm, and here is the zone of apposition. Zone of apposition is nothing but the peripheral areas of diaphragm attaching to the lower rib cage on the inner side. What happens when the patient inspires air? This dome-shaped diaphragm becomes flattened. That is what should actually happen when the patient inspires air. But in COPD, because of the hyperinflated lung, the diaphragm is already flattened, and with further inspiration of air, the diaphragm contracts more and it will pull the inner margins of lower rib cage inwards. This indrawing of the lower chest wall due to further contraction of flattened diaphragm is called as the Hoover sign. Now let's see, why does patient sits in a tripod position? The patient wants to reduce the effort of the sternocleidomastoid and the scalene muscles. That is why he bends forward by 45%. That will reduce the recruitment of the sternocleidomastoid and the scalene muscles. That will further reduce the oxygen demand because the muscles need not function as aggressively as they used to do before, and the oxygen demand is reduced. This will also restore the natural shape and function of the diaphragm. So these are the reasons the patient will sit in a tripod position, as you can observe in the image. The patient will also do pursed lip breathing. This is involuntary, though that is done by the patient. This increases the end expiratory pressure. See, the airways tend to collapse because of the reduced diameter, and while the patient tries to breathe with pursed lips, that is bringing the upper and lower lips closer together like this. While the patient does like this, there is significant buildup of resistance for the outflow of the air. That increases the end expiratory pressure and prevents the airway collapse. That will also increase the tidal volume and reduce the respiratory rate. You can look at this. See how he has pursed his lips and he is taking in breath. And you can also observe the tripod position where the patient has supported his limbs on the bed and he is leaning forwards by 45 degrees. Now, let's look at the MMRC scale of dyspnea. The Modified Medical Research Council has given this scale. The grade 0 is when patient develops breathlessness with only strenuous exercise. Grade 1 is when he develops breathlessness when the patient is hurrying on a level ground and walking uphill. Remember, uphill is just like 1. Grade 2 is when patient develops breathlessness when the patient walks at his own pace on a level ground or when he is walking with a peer. Grade 3 is walking 100 meters or a few minutes on a level ground. Grade 4 is when the patient develops breathlessness with dressing and undressing and the patient can even leave the home. How do we remember this? 0 is strenuous exercise that you can remember. Grade 1 is walking uphill. Grade 2 is the patient will not be able to maintain the same pace as that of a second person, that is a peer. Grade 3 is the patient will not be able to walk properly till 3-digit number, that is 100 meters on a level ground. Grade 4 is the patient will not be able to leave a 4-letter word, that is home. Okay, you can remember this MMRC scale by using this mnemonic. Now let's see the findings that you appreciate on examination. The expiratory phase is prolonged in these patients, and when you look at the shape of the chest, it is usually barrel shaped, and you can also appreciate the usage of accessory muscles of respiration because of hyperinflation and increased respiratory effort. And on percussion, you can appreciate a hyperresonant note, and on auscultation, the breath sounds are diminished on both the sides, and a wheeze, which is usually expiratory, is what you can find. And on general examination, usually you cannot appreciate clubbing, but if there is a new onset clubbing in a patient of COPD, suspect lung carcinoma in those patients. Now, let's see the evaluation. The gold standard for the diagnosis of COPD is pulmonary function test. Now, if you can look at the image, the residual volume is increased. Because of hyperinflation, there is residual volume which is increased. And the capacities which incorporate residual volume are total lung capacity and functional residual capacity. They are also increased. And the counterpart of residual volume is vital capacity, which is reduced. Right? It is very clearly apparent. And when you look at the FEV1 by FVC ratio, it is less than 0.7. That indicates a small airway obstruction. But is it reversible? For determining the reversibility, what you have to do, you can give a bronchodilator and look at the response for the bronchodilator. So the post bronchodilator FEV1, if it is less than 80%, then it indicates irreversibility. Okay, the reversibility is not there. And because of reduced alveolar gaseous exchange, DLCO is also reduced. And of course, the residual volume is increased, functional residual capacity is increased, total lung capacity is also increased, the counterpart vital capacity is reduced. Now, let's look at the chest X-ray. What can you appreciate? You can appreciate decreased vascular markings, that is indicative of emphysema, and flattened diaphragm, that is also indicative of emphysema. Here, you can appreciate on left side, you have a normal chest X-ray, and on the right side, you have the chest X-ray of a COPD patient. Compared with the left side, you can see there is increased lucency of the lung. This is because of rapid tapering of the vascular shadows. And here you can see the cardiac shadow is narrowed. So there is a narrowed cardiac shadow because of hyperinflation again. And here is a flattened diaphragm instead of a dome-shaped diaphragm, as in the case of a normal patient. A CT chest is a definitive test for establishing the presence and pattern of emphysema. On ABG, you can appreciate type 2 respiratory failure in patients with chronic bronchitis. In early emphysema, you'll appreciate type 1 respiratory failure, and in late or advanced emphysema, you'll appreciate type 2 respiratory failure. This we have already understood in the pathogenesis. And when you look at CBP, the PCB is increased because of this is a compensatory mechanism for chronic hypoxemia. This is called as the Gase-Box syndrome. And on doing 2D echocardiography, you can appreciate right ventricular hypertrophy and pulmonary arterial hypertension. Why is this happening? We have already understood this in pathophysiology. Now let's try to assess the severity. This has been given by the GOLD. GOLD stands for Global Initiative for Obstructive Lung Disease. You can simply remember this grading by looking at this mnemonic. 80 minus 50 is equal to 30. This GOLD grading is based upon the post-bronchodilator FEV1. When this post-bronchodilator FEV1 is more than 80%, it is grade 1 or mild. When it is 50 to 80%, it is grade 2 or moderate. When this is 50 to 30%, then it is grade 3 or severe. When it is less than 30%, then it is grade 4 or very severe. Okay, you can simply remember this grading by looking at the mnemonic. 80 minus 50 is equal to 30. And we also have the COPD assessment test questionnaire, which uses 8 items worth of 5 points each and the overall score of 0 to 40. But we commonly use this gold grading for the severity assessment. Then serum alpha-1 antitrypsin testing is recommended in all the patients of COPD. Now we have assessed the severity, let's predict the mortality. For predicting mortality, we have an index called as BODE index. B for BMI, O for obstruction, which is found out by looking at the FEV1 by FVC ratio, and D for dyspnea, which is found out by looking at the MMRC scale, and the exercise capacity of the patient, E for exercise capacity, that is made out by making the patient walk for 6 minutes and looking at the distance that the patient will be able to cover. That is a 6-minute walking distance. This predicts the 4-year survival in the patient. This is complex and there are multiple points involved in this index. Now let's look at the management. But before looking at the management, let's see the different drugs and their mechanisms of action. Here on one hand we have the bronchodilated airway and on the other hand we have the bronchoconstricted airway. So the mast cells which produce leukotrienes, these leukotrienes will result in bronchoconstriction. Chronic inflammation will again result in bronchoconstriction because of mucosal hypertrophy and smooth muscle hypertrophy. The patient will have bronchoconstriction. Activation of M3 receptors, that is muscarinic receptors, will also result in bronchoconstriction. And activation of B2 receptors, beta 2 receptors, will result in increased levels of cyclic AMP that will result in bronchodilation. Increased levels of cyclic AMP because of activation of beta receptors will result in bronchodilation. This cyclic AMP is metabolized by phosphodiesterase enzyme. Now let's look at the drugs. We can block the leukotrienes by using leukotriene antagonists. You can block the mast cells by giving mast cell stabilizers. You can reduce the chronic inflammation by giving corticosteroids. You can block M3 receptors by using muscarinic antagonists. You can increase the activity of beta 2 receptors by giving beta agonists, and you want to reduce the phosphodiesterase enzyme by giving phosphodiesterase inhibitors. So these are the different drugs that are used in COPD. Now let's see the drugs. The first step in the treatment is stop smoking, and then we have drugs like muscarinic antagonists. What we usually use are the inhalational drugs. They are short-acting muscarinic antagonist, that is ipratropium bromide. And we also have long-acting muscarinic antagonists, which are tiotropium and umeclinidium. Beta agonists, again, these are inhalational drugs that we commonly use. The short-acting ones are salbutamol and albuterol. Long-acting beta agonists are formoterol, olodaterol, indacaterol. All these drugs are available. Then we have corticosteroids. What we usually give are inhalational corticosteroids, which are budesonide and fluticasone. For symptomatic relief in exacerbations, you can use SAMA or SABA, but for reducing exacerbations in COPD, we'll use LAMA or inhalational corticosteroids. Between them, LAMA are preferred than inhalational corticosteroids. Then we have the phosphodiesterase inhibitors. We have a non-selective phosphodiesterase inhibitor, which is theophylline, and a selective phosphodiesterase 4 inhibitor, which is roflumilast. Then, if the patient is having hypoxemia, the oxygen support should be given if SpO2 is less than 90%, and oxygen support is the only modality that has shown to be having mortality benefit. And the target SpO2 should be maintained at a level of at least 90%. If the patient is in type 2 respiratory failure or respiratory acidosis because of reduced ventilation or hypoventilation, what you can do is you can administer non-invasive positive pressure ventilation for that patient for carbon dioxide washing out. Now, let's look at the protocol given by GOLD. The GOLD has designated the patients into 4 groups A, B, C, and D depending upon the risk profile and the severity of the symptoms. The patient is said to be having low risk if the patient had 0 or 1 exacerbation, said to be having high risk when the patient has 2 or more exacerbations or at least 1 exacerbation requiring admission into the hospital. The patient is said to have less severe symptoms or low symptoms if the MMRC scale is 0 to 1 or the COPD assessment test score is less than 10. The patient is said to have high symptoms if the MMRC scale is more than or equal to 2 or the CAT score is more than or equal to 10. Now look at the groups. The group A is low risk and low symptoms. The treatment is LAMA or LABA. Group B is low risk and high symptoms. Again, the treatment is LAMA or LABA. If the patient has high risk and low symptoms, the treatment is LAMA. And if the patient is having high risk and high symptoms, the treatment is LAMA plus LABA or LABA plus ICS. The inhaled corticosteroids are preferably used if the peripheral eosinophil count is more than 300 per microliter. This is all about COPD. Hope you find value in this video. If you really found value, please subscribe to the channel and share this with your friends. Thank you. We'll meet you in the next video.